Welcome everyone, and thank you to those joining us live and to those listening in afterwards. I'd like to warmly welcome all of our guests today and our speakers who I will introduce shortly. My name is Dalia Burgess and I'm going to be the moderator for today's session. My role within FIP is that I am the lead for provision and partnerships, and I'm delighted to moderate this webinar titled Innovative Cultural Sensitivity Training for Pharmacy Students. FIP's vision is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences, and education. We are pleased to be delivering this event, the first episode in the FIP COVID-19 digital events program. We know that the world's pharmacy team is fighting COVID-19 everywhere, working closely with other healthcare professionals and often putting their lives at risk to protect and care for patients and the public during these difficult times. So as part of this online program, we will be featuring regular events throughout the year. At this point, I would like to acknowledge that this particular webinar has also been coordinated by the academic pharmacy section of FIP. Today, we will be discussing innovative cultural sensitivity training for pharmacy students, an area in teaching and learning challenged by the onset of COVID-19. Please note that this event will be recorded, live streamed on Facebook, our profile, and will be freely available on our website via www.fip.org. To all those listening, please feel free to send your questions through the question box, and we will be picking those up throughout today's session. The program will start with a presentation from our first speaker, Dr. Mohammed Amin, on training for students on counseling diabetic patients observing religious fasting, followed by a presentation from Dr. Cherie Lucas, developing the working respectfully with Aboriginal people, RAP Toolkit, and experience from Australia. This will also be followed by our speaker, Dr. Gizem Golibna from Turkey, on pharmacy services based on cultural values. This will be followed by a panel discussion and the Q&A from the chat box. At the end of this session, participants will be able to identify key steps in creating activities aimed to improve cultural sensitivity among pharmacy students, describe strategies educators can use to engage students in learning about addressing the needs of patients from different cultures, consider strategies for integrating cultural sensitivity training in pharmacy curricula. I am now pleased to be introducing our speakers for this session. Our first speaker is Dr. Mohammed Amin, an associate professor at Beirut Arab University in Lebanon. A pharmacist by training, Dr. Amin received his PhD from the University of Wisconsin. His research involves clinicians, students, and patients in the US, Egypt, Pakistan, and Lebanon. He served as a faculty member at the School of Pharmacy in Egypt, the US, and Lebanon. And he is an associate editor of RSAP. Welcome to the call, Mohammed. Our second speaker is Dr. Cherie Lucas from Australia. Dr. Lucas is Senior Lecturer, Pharmacist and Clinical Education Manager for the Master of Pharmacy degree at the University of Technology, Sydney in Australia. She's also the lead for the RAP, that's Reflective Practice Project, working respectfully with Aboriginal people. Cherie's former work and collaboration in the area of reflective practice has been awarded multiple awards, including university, national, and international awards. Welcome, Cherie. Our third speaker is Dr. Gizem Golibna, who received her PhD from Ankara University in Turkey. Currently, Dr. Golibna is a postdoctoral researcher at the University of Nottingham in the UK and a member of the research team of Commonwealth Pharmacists Association. She's interested in qualitative research, exploring pharmacist professional identity, patient experiences of pharmacy services, pharmacist attitudes on providing pharmacy services, and ethics. Welcome to the call, Cherie. With that, I would like to start the program by handing over to my colleague, Mohammed, who will start the presentation, walking us through his academic research on an online module addressing counseling patients with diabetes, observing religious fasting. Welcome, Mohammed.
Thank you, Dalia, and thank you, FIP, for hosting this, and we're glad to see so many people attending. I'll be presenting our experience with an online module, as Dalia mentioned, addressing counseling patients with diabetes, observing religious fasting. This is a brief outline of what we'll address with this session. All right, so religious fasting is practiced across different faiths. So there's the Islamic fasting, and it happens in Ramadan, which is the obligatory Muslim fast, but there's also some kind of religious voluntarily fasting that happens throughout the year. There's the Jewish fasting, Yom Kippur, and those two have some commonalities. Ramadan, it happens for 1 month. Yom Kippur is only for 1 day, around 25 hours. Ramadan is from dawn to sunset, and they both involve abstaining from food and drinking for a significant period of time. This year in 2021, Ramadan started a week ago on April 13th, and Yom Kippur should start around the evening of September 15th. It usually starts sometime in the fall. So there is, with the difference in the duration, but there is some similarity in the way Islamic and Jewish fasting is observed. There's, of course, the Christian fasting, Lent, and it can take different forms across also different sects. There's the Hindu fasting. Shagana is one of those examples, and it can be observed differently from one person to another. Some people give up one meal, some people give up certain types of food, others just give up meat. So it can be practiced differently across different faiths. Despite religious exemptions, the one thing across different religions, Muslim, Jewish, is that those patients, if fasting would pose risks to them, those patients have a religious exemption for fasting. But we know from statistics that many patients with diabetes choose to fast. Matter of fact, according to the International Diabetes Federation, around 64 to 79% of Muslims with diabetes fast during Ramadan, including type 1 and type 2 diabetes patients. Fasting, although it may have some benefits for some people with mild type 2 diabetic patients, some people, not all type 1 diabetic patients, but some of them, and some even type 2 diabetic patients, it may pose risk for some of them. Prior studies indicate gaps in communication between patients and health professionals, including pharmacists. Sometimes that communication does not happen at all. Sometimes people do not have the questions between patients and clinicians, including pharmacists, around fasting. Sometimes that communication happens really late. So first or even second week of Ramadan. Little research has addressed religious fasting among students and training students to take care of patients observing religious fasting, especially patients with diabetes. And so our plan was to contribute to addressing this gap. So our aim was to formulate an online and easy to implement module on caring for patients with diabetes at the University of Wisconsin, and to evaluate this quantitatively by assessing its impact on student self-efficacy, as well as qualitatively by analyzing students' write-up in relation to their experience taking the module. Just a little background before we get into the details of the module itself. This is some of the research that I did in collaboration with my colleagues at Manchester University in Indiana, not Manchester, UK. And in that research, we explored perspectives of clinicians and patients in the United States and in Egypt. And it also included us trying to develop a tool. We called it ROMCOM, that would help patients communicate with clinicians and clinicians communicate with patients. So there are two versions of that tool, a clinician version and a patient version. From a therapy perspective, so there was always a clinician who had to make a choice. Should I tell patients to fast? So that I tell them not to fast. What is their risk level? How do I manage their medications? And there is some guidance to help with that. So there is some guidance. The International Diabetes Federation, in collaboration with the Diabetes and Ramadan International Alliance, called DAR, they have issued guidelines, and they update it every year. There's also some guidance with patients observing Yom Kippur. This is an example of one of them, but not as much that is out there. So there's therapy background that needs to be taken care of, and communication background that needs to be taken care of. This is the setting for our study, the School of Pharmacy at the University of Wisconsin. This is the Renovum Hall. This is where I studied for my PhD. So this is where the connection is coming from. We had worked on this with third-year PharmD students at the University of Wisconsin School of Pharmacy. This is what it's on spring 2020. This is the usual setting. So the usual setting is to have simulated patients, and the student pharmacist, the guy smiling that in that picture, they are working with that patients and helping them with various problems throughout the semester. But of course, because of the advent of COVID last year, our original plan was to have standardized patient acting as a Muslim or a Jewish patient, but we could not do this, of course, because of the pandemic. And this is where our experience, I think, would come in handy. So in light of COVID, the current module that we're about to describe can help you if you're looking to train your students in this area. But even post-COVID, in a post-COVID world, assuming that one exists, you could still use that simple setting if you don't have access to resources such as simulated clients and the fancy communication labs. You can still have something online and can still give a student a background on this. This is the overall design of the module. So we had a pre-test of confidence. We asked students to rate their confidence on a number of items that I'll be describing briefly. And then we introduced the module on itself that I'll be describing now. And then post-test, there was a post-test, asked them about their confidence. We asked them about the perception of usefulness of the module. And then we asked them to write their reflections on what they liked and did not like about that module. So the module started with an introduction describing Ramadan, what Ramadan is, and introducing the student to clinical guidelines on caring for patients with diabetes, considering Ramadan fasting, such as the one you saw earlier. And then we presented them with a case, a 48-year-old Muslim patient with type 2 diabetes, considering fasting. We asked students to reflect. What do you think? We asked students, what do you think are the challenges in working with this patient? What do you think are the opportunities in communicating with this patient? Students were presented with brief videos, and we'll show you those in a minute, or at least one of them, videos summarizing clinical and patient version of ROMCOM, the communication tool that we created. And then we asked students to reflect, to comment on ROMCOM. What do you think its application is to the presented case study? What is its utility? Facilitators and barriers. What do you think would help you use that tool? What would be a barrier for you that would prevent you from using that tool in practice? We asked students to search for information on Yom Kippur and Shagana, which are kinds of the Jewish and the Hindu fasting. And we asked them to reflect on how they think counseling a Jewish patient with diabetes observing Yom Kippur or a Hindu patient observing Shagana would be different from the presented case. We presented them with an article that describes options on caring for patients with diabetes, such as the one I presented earlier on the pharmacotherapy of caring for patients with diabetes, considering to observe Yom Kippur. And we asked them to think of components of rom-com that could help them in counseling those patients, a patient who would observe the Jewish fast or a patient who would observe Shagana. The last part of the module included students being asked, presented with a second case for a 69-year-old Jewish patient with diabetes considering fasting in Yom Kippur. And then we asked students to complete a written script that illustrates the conversation that would take place. So imagine that they would have a conversation between them, the pharmacist, and that patient, that lady, 69-year-old lady, considering fasting in Yom Kippur, using motivational interviewing techniques. I'm not going to get, for the sake of time, what motivational interviewing is, but it's a general communication style that strengthens patients' motivation towards the goal, includes empowerment, empathy, collaboration with the patient, helping them resolve ambivalence. We analyzed the data using descriptive data. Of course, we calculated internal consistency for the scale that we created for the purpose of this assignment. We had good internal consistency, used pair t-test, and finally we used conventional content analysis to analyze the open-ended question addressing what they liked and did not like about the assignment. So these were the perceptions of helpfulness of the module. So we had 44 plus 28% rating the module as useful or help or extremely useful. So 72%, around 7 out of 10 students thinking the perception is useful, extremely useful. And we had some people thinking, of course, somewhat useful, 1 in 4, and then 5% slightly or not at all useful. Next slide, please. All right, and in terms of confidence, we had an increase in the confidence throughout. So the increase in confidence of students providing an environment at the pharmacy where they encourage patients from different cultures to approach them, recognizing opportunities to work with different cultures, confidence in communicating with different cultures, starting a conversation, developing a therapeutic plan, practicing motivational interviewing. All these things have improved. Next slide, please, Dania. Other things that improved were the ability to recognize opportunities and challenges, working with Muslim and Jewish patients, communicating with them. And some of the areas, the questions look at items 10, 11, and 12, and 13, that have seen some of the highest increases. So their ability to start a conversation with a rabbinic, a Muslim patient in Ramadan, or a Jewish patient observing Yom Kippur, their confidence in their ability to develop a therapeutic plan for a Muslim patient, or even work and practice into motivational interviewing for Jewish patients. And those things had significant increase as well. We also had the qualitative portion for this module, as I mentioned. So some of the things, the quotes that we're having from students, opened my eye, or was a realistic assignment, or something like gave me a deeper appreciation for those cultures. It is something that I would not have maybe even thought of to ask, but instead just overlooked it. Now I feel like I have a resource. Some people said the transcript that they wrote, some of the videos they had, they would use these as resources to help people in the future. I would not be taken completely off guard if I'm asked about it, or I've seen a Muslim or a Jewish patient or a Hindu patient. As a healthcare provider, and this is one of the things that I thought, this was one of the key things that we had in mind. We wanted students to be more empathic with this class of patients and with other patients as well. So we wanted them to put themselves into the patient's shoes. And I think one of the students, one of the quotes helped us, show that. He said, it would be easy to just tell someone following Yom Kippur that they should not fast because of their health. But I thought of what would mean to me if someone told me something similar. So they're putting themselves in the patient's shoes, being more capable, hopefully, of showing empathy. Motivational interviewing script. So some people liked writing the motivational interviewing script because it helped them think hard about it. Some people thought it was a bit boring to write. The script was not as helpful as the other parts. So some people would have liked to do a video where they would show, create a video that they would show themselves counseling such patients. So I have different views on that. A number of students expressed satisfaction with learning about multiple cultures. And this is one thing that actually surprised us, honestly, because when we were designing this originally, we thought we didn't want to overwhelm them. We're introducing Muslim fast, Jewish fast, Hindu fast, throwing it in there. And we're surprised that a number of our students said, I want to learn about different cultures. I want to learn about more cultures. Our concern was not to overwhelm them, but they ended up wanting to learn more, which is a good thing. Students felt the opportunity, of course, to practice with a simulated patient could make the experience. Remember that this is what they had earlier in the semester, working with simulated patients. So some people would have liked to take this to the next step and have it a simulated patient. Of course, this was not possible with COVID going on, but it is our plan when they go back to the normal circumstances. Do we have time to play the rom-com version, Dalia?
Yes, we do.
All right.
And Mohammed, I want you to confirm that you can actually hear the sound as well.
All right.
So here we go. Thank you.
All right, I think it might just take a second to load that. So. Alrighty. So this was the clinician version of Ramcom that we showed to students. Of course, we shared with them the article, but we also have the video because not all students are going to read the full article and wanted something that would be visually appealing to students. We're going to show you the first, for the sake of time, only like the 20 seconds out of the patient version, just to show you what it looks like. Alrighty, so this was the patient version of the tool. Again, it's about 3 minutes or so, and I'm happy to share with you if any of you is interested. We used Powtoon, the software, to create it. I'm happy to share the link for that if anybody wants to use them. They're available on YouTube. So next slide, please, Dalia. All right, I want to take the time to thank, of course, I want to acknowledge that there are limitations for every research. We did not measure their actual improvement in ability using simulated patient. That will be the next step on to do, and God willing, after we return from the COVID. I want to thank my collaborators, Professor Betty Tuning from the University of Wisconsin, Bunyan, Arvin, Marwa, wonderful group to work with. All right, and this, I also want to leave you guys with the resources. If anybody wants or is thinking, any of the fellow teachers out there are thinking of using this or using parts of them, these are things, the Ramcom clinicians, the papers, they're free to download, the clinician version, and the YouTube link is right there. I'm happy to share it in the comments. And this is the paper, again, for the Jewish fast, the therapy, and the International Diabetes Federation Ramadan guidelines. If some people want to read more about motivational interviewing, this would be a good resource as well. This concludes my presentation, and I'm now more than happy to pass the torch to my colleague from Australia, Dr. Shari Lucas.
Thank you very much, Mohammed. Thank you very much, FIP, for allowing me to present this work. This is work that's been done in Australia, and I just would like to acknowledge that the work was guided by Indigenous academics at my university and another university as well at Western Sydney. And also I would like to acknowledge the consultation through the Indigenous elders in the local community. So the development of the RAP Student Toolkit is a reflective practice toolkit. And the need for that was because we wanted to support our non-Indigenous students out on placements, and so they could work respectfully with the Aboriginal people, Torres Strait Islander people. At UTS, the university I work at, we've introduced what's called an Indigenous graduate attribute, and that is to support the non-Indigenous students in these placements. This is also to prepare our students to be culturally safe healthcare providers. And there is some terminology around cultural safety. So cultural awareness, cultural sensitivity, and cultural safety are slightly three different constructs slightly, and one leads into the other. So cultural awareness is defined by the Australian Human Rights Commission as understanding that we do have differences that exist between different cultures. And that is actually the first step towards cultural sensitivity. Now, cultural sensitivity is that one step further where an individual undergoes reflective practice in terms of reflecting on their own cultural identity and their own life experiences. And that's in terms of their own attitudes, their own beliefs, their own value system, and their own assumptions. And then cultural safety is basically the outcome of that education. And that actually enables a safe service to be defined by those who receive the service. So reflecting on someone's own cultural identity, and then recognizing the impact of their own personal identity and cultural identity, and what that impact is on their professional practice. That is what is cultural safety, a cultural safe healthcare provider. And the whole reason why we're looking at developing this particular toolkit was also to ensure there was no harm to Indigenous communities when non-Indigenous students were working in these communities. Next slide, please. So the research that underpinned the development of the toolkit, it really involved 2 qualitative studies. The first study involved pharmacy students and their learnings and reflections. And the students that were invited to the first study, they actually were immersed in rural, remote areas in Australia in Indigenous communities for their normal placement. And they had 4 to 6 weeks out in those communities. And then once they've done that, they reflected on the learnings there. They also were invited to an urban Indigenous community where they undertook cultural modules. They undertook historical walks and so forth in that community. And we looked at what their views were in terms of what would support them to work respectfully with the community members there. The second part of the project, the previous slide. Second part of the project involved clinical partners. And the clinical partners that we utilised were both urban and rural clinical partners across 7 different health disciplines. So we utilised clinical partners in pharmacy, orthoptics, physiotherapy, speech pathology, genetic counselling, clinical psychology, and Indigenous health. And those clinical partners work with the students in these Indigenous communities. And so they had a good understanding of what was needed as well. So we conducted focus groups, and for the remote participants, we used the same open-ended questions on an online questionnaire. So these 2 studies informed the development of the inclusions in the RAP toolkit. The next slide, please. Who was involved? I was lucky to and fortunate to lead this project, and I was the only non-Indigenous person leading this particular project. The grant team members included Indigenous academics at various stages of the project. The project was led by myself with the basis that it was a reflective practice project, and that was my area of expertise. But of course, I could not have done this work without the Indigenous academics guiding me all the way. And also the facilitators for the focus groups included Indigenous academics from different universities. So the input from them was valuable. The draft inclusions for the toolkit were presented to Indigenous elders from the local urban community. And that is very important to have that consultation with people of Aboriginal authority. And the final toolkit inclusions followed that consultation. So thank you. The toolkit inclusions that were derived from the 2 studies involve 3 sort of components. So we looked at some exemplar counselling videos, and I had filmed a practicing pharmacist to counsel 2 Aboriginal patients, 1 female, 1 male, 1 with a new insulin medication and 1 with a new blood pressure medication. And we deliberately had some aspects of the counselling that were needed improvement, so that the students could work through this in their workshop as well, to see what was required and how to build rapport with the counselling and so forth. The other aspect was the research aspect of the toolkit. So the students, this is a self-directed learning aspect. So they really had to think about the history, the buildings, the artworks in the area that they were going to be immersed in. Now, given COVID didn't allow all the rural placements and the border closures didn't allow that, these 2 aspects, the research and the videos, were workshopped via Zoom, and we used the urban Indigenous community, which is very close to the university, and we used that as an exemplar to research the history, buildings, artworks, and so forth, and the local services that are available. So the students also had to also researched the government schemes to access medications, and Closing the Gap is one of those schemes. And one of the other areas of interest was the Aboriginal slang. So researching the Aboriginal slang, the colloquialism, so when they are immersed in these areas, that they are quite equipped in those sort of, in the slang. And obviously the cultural safety learning modules were attached to that as well. Part of the toolkit was the reflective practice component. So prior to attending any placement or attending any of these workshops, the students were asked to reflect on their own culture. And that is the cultural sensitivity part of this. So the reflective practice part on their own cultural identity. And given the fact that they were then going to go to placement and then follow up on placement after placement, so we used Sean's model, the 1983 model of reflection in action, reflection on action. So in action whilst they're during placement, and on action following placement. So they would reflect on how their assumptions, beliefs and so forth had changed as a result of the placement. Thank you, next slide. So embedding the RAP toolkit into a health curriculum, I initially embedded it into the pharmacy curriculum in 2020 in our second semester subject, and it is being proposed to be embedded into the nursing curriculum for this year. The second semester subject is a clinical placement subject. It is supported by workshops, but our students actually undertake more than 500 hours of clinical placements over a 2-year period, and significant hours are associated with that particular subject. Thank you. Next slide, please. So what do the students think of this? The RAP toolkit was extremely useful in ensuring that we were preparing ourselves the best way possible to work with Indigenous communities. It made me more culturally aware and considerate of Indigenous populations, allowed me to gain better understanding of what is expected of me as a healthcare professional. I very much enjoyed the activities that they were made available in the toolkit, and I recommend that future healthcare practitioners of all fields use it when preparing for themselves to work in these communities. It made me aware of the Aboriginal medical services. However, I still need to research local services. So there was a bit of a gap in their knowledge, and if those who didn't conduct the self-directed learning aspects very well, they did miss some of these areas. I think the RAP toolkit has prepared me to work with Indigenous peoples by presenting different terminology that I should be aware of, and prepared me to be thinking differently in different situations. So this was part of the anonymous student feedback, and this was the initial feedback. So that was quite positive. You'll notice the artwork on the other side of this slide. The toolkit is actually, I'll just show you what that looks like. It's basically a booklet that they work through, and they have maps of different areas in Australia and so forth. And this is attached to counselling videos as well. And the artwork that's related to the toolkit was undertaken by an Indigenous artist. Next slide, please. Okay, so in terms of what we learned as pharmacy educators and working with different cultural groups, understanding your own culture to facilitate understanding and respecting another culture was very important. And I did learn that myself. I undertook some cultural safety modules, and at the initial cultural safety modules that were undertaken in the urban immersion, and I actually attended that myself with the students, we all had to open up about our own background, our own cultural identity. And it was actually a really good opportunity to get to know students and what they identified and how they identified. Also understanding the lingo, which may differ with different cultural groups. So communication is the key. The students found that researching the slang and the lingo, the colloquialism, was very interesting for them. And obviously undertaking those learning modules. The learning modules were facilitated by Indigenous academics, and also they were supported by the Indigenous community members at the community centre. and obviously never underestimate the power of building rapport between people. Next slide, please. Just some acknowledgements. I actually led a $20,000 grant that was granted by Sphere Sydney Partnership of Health, Education, Research and Enterprise in the Aboriginal Health and Wellbeing Small Grant Program. And I was very fortunate to work with some amazing people in this space. And the publications were published with an Indigenous academic, and focus group facilitators included Indigenous academics from the University of Sydney and Western Sydney University. I'd like to acknowledge the artwork that was also introduced into the toolkit as well. Thank you very much. And over to Gizem, one of my colleagues. Thank you.
Thank you, Sherry. Before I'll start, I'd like to say thank you for FIP members for considering me as a panelist on this webinar. It's a pleasure to be with my colleagues and the team of this webinar today, and to share my experiences regarding cultural sensitivity training for pharmacy students today. When I was asked to be a panelist on this webinar by Mohammed, I thought about what I can share with you, and I decided to provide some practical examples from the practice setting from Turkey on cultural sensitivity. And now I'd like to provide a brief standpoint of what pharmacy practice looks like in terms of responsiveness toward cultural sensitivity. Moreover, how pharmacists perceive culturally diverse patients and approach to them in the practice setting, especially community pharmacies in Turkey. I would like to start with our research findings, which is newly accepted to be published in Journal of the American Pharmacists Association. As a background, in the next slide, I'm going to mention our motivation to conduct this research was to understand the perceptions of community pharmacists in Turkey to provide certain types of pharmacy services contradicting their cultural, personal, or religious values. Because in recent years, like many other countries worldwide, a conservative conjecture has based on moral concerns and personal beliefs have become dominant in Turkey as well. The most noticeable characteristic of this era is that belief-based approaches have become more prevalent in healthcare practices. Some pharmacists have been opting out of certain pharmacy services, particularly distributing cognitive enhancers, contraceptives for moral reasons throughout the world. So when examining the literature, no study has been found to explore the pharmacist's refusal or feeling hesitancy to provide pharmacy services contradicting their cultural norms in an Islamic country. So before expressing the results of that study, it can be better to set the context in Turkey. Turkey is the only secular state that is mostly Muslim. We have no culturally diverse patients when we compare with US and Australia. So although Turkish law and other social structures involve elements of both secular Western and Islamic Eastern cultures, Islam has a great influence on society, especially in rural areas. So it was worth examining how personal and cultural norms affect the service provision. So as a methodology in the next slide, you'll see we made some structured interviews with 25 community pharmacists in Turkey to understand their hesitation, their willingness to provide certain types of pharmacy services, such as distributing contraceptives or some medicines, including religiously forbidden products, for example, pork based, for example, alcohol, including medicines that might be a concern in the Islamic world. So additionally, nowadays in Turkey, especially in the medical setting, we have started to recognize that some healthcare professionals are reluctant to consult with the patients of the opposite sex. So while we were trying to understand what is the current situation in Turkey in terms of this reluctancy to provide certain types of pharmacy services, we had a chance to understand the sensitive topic in a different perspective. So as a result, in the next slide, you'll see, yes, we saw some pharmacists have been exploring an ambivalence whether to provide pharmacy services to the patients of the opposite sex or to distribute these certain types of medicines that I mentioned, contradicting their personal or cultural norms. On the other hand, we have seen that even pharmacists have no cultural sensitivity or religious sensitivity during service provision. They have been experiencing some difficulties while providing pharmacy services when the patients have their own cultural sensitivity. Patients sometimes might have their own preferences and demands. Sometimes they do not want to use pork-based or alcohol, including medicines, or they feel hesitant to get the service from the opposite sex. So they might have this kind of specific demands from pharmacists. In these cases, we saw in our study, we understood that pharmacists didn't know how to approach and interact with these patients. So they didn't know how to behave and respond to their specific requests. And actually, one of the reasons of not being able to effectively communicate with these patients was that pharmacists have their own overgeneralized beliefs about these particular patients. So some pharmacists were discriminating these patients implicitly and approaching them in an exclusionary manner. We saw that in our studies. So one of the interesting findings encountered in our study was that there was an issue in terms of interacting with Syrian refugees. Maybe you are aware of that. Currently, Turkey has been hosting approximately 4 million registered Syrian refugees. So this was another problem identified in our study. They didn't want to approach them. They didn't want to consult them. So based on lessons learned in the next slide, based on lessons learned from the practice side, I would like to offer some recommendations for how to develop cultural sensitivity training curriculum for pharmacy students. So, of course, the content would depend upon where you are living, in which region your pharmacists are serving, yet there are some topics of contents that could be covered and that could be included in our curriculums if you are willing to develop similar courses at your organization. So to me, the first two important topics to be covered would be stereotyping and discrimination. So as well as we all know that stereotype is defined as fixed, overgeneralized beliefs about certain types of groups or a particular group. So stereotypes can be explicit because the individual is willing to verbalize it and acknowledge them. Or on the other hand, it could be implicit, existing in the individual's unconsciousness. So the concern here starts with when people start having or exhibiting negative feelings and emotions based on these stereotypes, or patients who have cultural sensitivities during the service procurement process. So this may result in prejudicial misconceptions about the group, and it can lead to discrimination. So I think this is essential, that resulting danger occurs when people with prejudicial feeling become unwilling to think their attitudes and behaviors. As a result, they can easily justify these prejudicial behaviors and attitudes and do not even consider their consequences. So this may result in disastrous relationships, conflicts, and harm to the targeted groups. So providing the essential knowledge about discrimination and stereotyping would be the key, and to me it's the starting point in developing cultural awareness and sensitivity training. And secondly, needless to say, approaching to culturally diverse patients' needs an advanced level of empathy. So sensitive topics to be discussed require self-disclosure. So self-disclosure may be a bit of issue for some patients sometimes, so they cannot feel comfortable to say what they want to say. So we need to take the necessary time and consciously work to establish the trust. So we have to see the patient's point of view, even it seems nonsense. So we have to consciously attempt to suspend our judgment. In order to achieve these ones, we need to include, for sure, communication skills to the curriculum. If you want to enable our students to respond to patient-specific demands. So consequently, the basic philosophy of not behaving in a discriminative way or communicating in a patient-centered way or building trust or whatever it is, coming from respecting human beings. So in my point of view, why do we need, so people can ask, so why do we need to respect human beings? So in my point of view, this answer would be best taught by including ethics in a part of the course or in a part of their intervention. So all of these discussions that we have been coming through during this webinar is basically because of our ethical, personal, cultural dilemmas. So solving these dilemmas needs an ethical reasoning skill. So we need not only to develop ethics in cognitive domain, but also in both affective and psychomotor domain. So before wrapping up, I would like to point out another important issue about professional code of conduct. So while embedding cultural sensitivity training into our curriculum, there might be a critical threshold that should be paid attention. Respecting patients' preferences and their sensitivities and providing culturally sensitive services to the patients may sometimes make people think their own personal and cultural sensitivities. So providing these services based on patients' cultural sensitivity could activate an impulse within the pharmacist, such as, what about me? Well, how can I cope with my own personal and cultural sensitivities? So in an Islamic world, there might be a question. So I think this is a critical threshold that might create a justification for being reluctant to provide certain types of services, as I mentioned previously in our studies. So students or pharmacists might think about if there's a right for patients to demand or expect to get the service based upon their cultural sensitivities or needs, wherever it is, then I can have a right to reflect my own to my practice. So trainers should draw the boundaries between our personal freedom and our duty to serve as a pharmacist. So our efforts on empowering students to be sensitive to this cultural diversity and patients' preferences shouldn't cause students to misunderstand that they can practice in a way that they can reflect their personal cultural norms in their practice, of course, if there's a possibility to harm the patients. So thank you. It's all from my side.
Thank you so much, Gizem. Thank you so much, Cherie and Mohammed, for your thought-provoking presentations. I'd like to ask you all to maybe keep your videos on while we transition into the next stage of the presentation, and that is just looking at some of the questions that have been posed to you through the Q&A box and also through the chat box. And so our dear colleagues and friends on the call, if you have any questions or comments that you would like to share with our speakers today, please do so, and we will pick those up as we progress in this panel discussion. I will keep the screen on for just a second as we field the Q&A box, but I just wanted to start the panel by perhaps asking our speakers if they picked up any questions as Gizem was just doing her presentation, and whether any of those were for you to share as well with the rest of us. Was there anything on the Q&A that we could share with the rest of the group?
Everything was answered.
Go ahead, Cherry, yes.
No, go ahead, Mohammed, go ahead.
I was just gonna say a lot of actually great questions, so thank you everyone for attending and for sharing your thoughts. We really appreciate that. I think one of the questions from Lotte from Denmark, I think it is like, what do you advise, if you're working with interns and students, what would your advice be? And honestly, it's just approaching this as a student myself, because there is always something new to learn, and trying to learn more about being cognizant of my surrounding and my needs, the patients I work with. Quite often, patients may know that as sometimes a clinician, we may not know everything about Islam or Judaism, but they would at least appreciate you giving a shot and trying to learn about this and approaching this with humility and wanting to learn and help. So you'll always, in terms of at least of culture, I think, work with new things, especially those of us who work with diverse communities like sharing in Australia or the US or Canada.
Thank you so much, Mohammed. Actually, as I was listening to the three of you, a lot of things were coming to mind on this very important topic. And one thing that came to mind, I'd like to direct this question to Cherie, if I may, and that is, what should pharmacists consider, Cherie, to be able to be culturally sensitive in their practice? Your thoughts on that?
Yeah, thanks, Dahlia. Look, there's a cultural sensitivity and the considerations around that. It really involves them considering their own identity, really thinking about that, their assumptions about their own health, illness, and people in general, their personal definitions of health, and their patients' definition of health as well. So what their patients think of that. Also, what is the definition of health in terms of the society and their environment, and the implications in terms of how it affects your practice and the consequences of that. So there's a number of different elements that you need to consider working towards being a culturally safe healthcare practitioner.
Thank you for that, Cherie. I'm not sure if Mohammed or Gazem have any further comments on this particular question, but what makes me think about next is to be culturally competent in healthcare, and whether that is different from what we're talking about. How do we ensure that not only pharmacy students, but also pharmacists are developing their cultural competence, being able to address patient-specific needs, whether it's social, financial, cultural? What are your views on cultural competence? Is that something that we can touch on here, or have I gone beyond scope?
Cherie?
Oh, that's good. Actually, my colleagues actually don't like to use the word cultural competence, to be honest. Okay. They think it's just, well, why just be competent? Like, it's just like they want you to be better than that, actually. Yeah. So I'm not sure if that terminology is often used in other countries as a sort of like, it's almost saying that's the minimum standard. We want to be beyond the minimum standard. So that terminology is kind of almost frowned upon with my discussions with my Indigenous colleagues, and I'm actually learning a lot from them. So I'm not sure. I'd love to hear other people's views, because being competent in something is it's almost suggestive of just that minimum standard, and we want to be beyond that. We want a culturally safe healthcare professional. And we want to develop that cultural sensitivity through your own reflective practice, your own reflections and learning on your own life experiences. So it's a lifelong learning process, not just, oh, we got to that standard, then that's fine. So it'd be interesting to know what others think about that.
Thanks, Cherie. Mohammed? Gazem?
Yeah. So go ahead, Gazem. Yeah.
I agree, Cherie, because it's a lifelong learning. So when you feel confident when you graduate from the school, when you practice in the practice settings, your values can be changed, and you have to align your values according to the patient's demands. So yes, we have to be beyond these competences, and we have to develop ourselves when the practices are changing, and we have to up to date, and we have to reach the up-to-date information, so and enable us to sensitive in our way.
I think it would be good to have an open communication and a two-way channel with practitioners as well, with pharmacists, the community setting, in the hospital setting, because sometimes listening to them, they tell you, we're seeing patients who need this or that. And I think this would be, an opportunity for us to think of, okay, this is something that we need to tackle, whether that's in education, in professional education, or even on CE activities. So I think sometimes it's listening to pharmacists who are, right there and practicing pharmacists and telling us what their needs are. Sometimes, again, in immigrant communities, demographics have changed. People from a certain with a certain ethnic group have moved in, and we need to work from there. So I think it's always being willing to adapt and change.
Thank you for that.
One of the questions. So there's one of the questions that's just come up on the panel here.
Yeah.
I'm just looking at it. Zainab has said, I think it's also important not to use the terms religion and culture interchangeably. And I totally agree. They are two separate things here. And I totally agree. What are your thoughts, Mohammed and Gizem? I mean, they shouldn't be used interchangeably. I'm not sure that they are in the literature, but they are certainly different.
I think so too, Sherry. And I think there was actually a discussion on spirituality and religiousness, I think in AJPE, the American Journal of Pharmaceutical Education, must have been last year or so. And there were some responses from two different viewpoints. And I agree with you, Sherry. I think it's very important to separate the two, because these are, they do not, sometimes you would have a Muslim American and the way they identify with the culture, sometimes it may be more than, some other person who has the same religion as the majority, but who is not living. So I think it's just, yes, it's always good to disentangle those things, even if you're thinking of coming up with interventions or working with, so you would be having a smarter or more tailored intervention.
Mm-hmm.
Yes, I agree, Cherry. Yeah, because you have to narrow down your aspect and what you want to do in your intervention. So if you want to focus on religious sensitivity or cultural sensitivity, but I think that the cultural shapes our religion and our thoughts. So yes, it can not be used interchangeably, but we shouldn't forget that these are so binded terms. So they are affecting with each other.
Thank you so much for that. We have a comment and a question from my colleague, Zakaria Nazar. I'll just read it out here. Some research that I have been involved in focused on where the Muslim community seeks advice on health and well-being, where there may be implications on their religious practice. The research revealed that their local imam is a common source for such guidance and advice. What are your thoughts regarding extending your research to include other stakeholders, such as community religious leaders? Sure, if Mohammed, you'd like to comment on this particular one?
I'm happy to share my thoughts on this, and thank you, Zakaria, for this comment, for your insightful comment. At some point, honestly, this is something that we considered at one point, is to expand those partnerships with imams or encouraging people to talk to their clinicians at some point. So I think of this as a really comprehensive and a really nice intervention. I think is to include imams or sheikhs or other religious figures or rabbis or whatever the religious figure is. Sometimes it's a bit of a, sometimes you're surprised by findings. One of my master's students, she's working on the intention of pregnant women to fast, and we're quite surprised that compared to their own mothers and other determinants, the opinions of the religious figures we're as surprised as probably you would be. So I think it's worth giving a shot in terms of being comprehensive and working from an intervention that tackles all aspects. And I think it's also having those partnership with those imams or rabbis. I think it would be also good in terms of establishing that partnership that would be helpful in other parts also other things that have to do with religion and faith.
Thank you, Mohammed, for sharing your thoughts. One of the questions that you have previously answered, Mohammed, on the Q&A, I think it's quite a good question to share with the rest of us, and that is from one of the attendees who has asked about any current standards or regular training for culturally sensitive training for pharmacy students when they're on rotations, clerkships, and other work-based training. And so you've nicely answered it, Mohammed. I'm not sure if there's anything else that you'd like to add, or you'd like to see your answer, or would you like me to read it out to everybody?
Sure. So I just referred the person who asked to the ACPE standard, American Council of Pharmaceutical Education. They has some standards on cultural sensitivity. And there is also some work that has been published in the American Journal of Pharmaceutical Education, AJPE, if you're looking into specific experiments on immersion and other things. So these are things you may want to consult. Again, I think the key thing is just, being cognizant of what group you're working is, or you're working with, what group has the needs, and then you can come up with a strategy on how you can be of help to them, or how you can train your students to work with them.
Yep. Thank you so much for that. Siri, was there any other advice or recommendations from your research journey in this field on perhaps where people can find further information about training for pharmacists in this field?
Yeah, look, in terms of culturally safe modules and so forth, the interesting thing that I've found managing students and going out in these different placement sites, each one of the sites actually have different types of modules set up, which it's interesting. There's no standardization between these things, but that's probably correct, because each one of these areas have different, there's differences between these areas as well. So across the board in terms of pharmacy education, there aren't any sort of kind of standard processes around the development of these modules. I'm not aware of any standardization around that. But then again, I guess you need to adapt and tailor it to the different areas. So I don't think I've really kind of answered your question very well, but there isn't in terms of what learnings you can get from that, or how those things are developed. There's diversity even in those modules, and the education across all Australia. Actually, there are some major elements there. The elements of reflective practice, reflecting on your own culture and those sorts of things. But when you unpack the other elements, how to equip the students, these things differ across different rural settings. So that's an interesting question that you brought up.
Thank you, Cherie. Thanks for that. Another question that we have got here is, how can we foster collaborations such as the ones that our speakers have presented today? So the idea of fostering collaborations with other researchers, other academics, other pharmacists, in this case. I'm not sure what your thoughts are on this, lessons learned from your journeys in this research. Who would like to start with that?
I might take that actually. Being non-Indigenous, this was an extreme learning curve for me, to be honest. And I actually feel quite privileged to be working in that space. It is a different way of presenting yourself. It's a different way of counselling patients. It's very much building a rapport, getting to know the person. You just don't go into this is your medication and so forth. The whole way of doing things is a new way of working with these types of communities. So, and given the fact that there's a huge number of Indigenous people in Australia, for example, and across different urban and rural communities, our healthcare, future healthcare providers need to be equipped with these attributes. They really do. They need to be equipped with knowing the services, knowing how the counselling, how to build the rapport, understanding some of the differences. All of these things have to be learned, and you can only learn that from a higher education setting and building rapport with Indigenous academics, Indigenous elders, Indigenous community members, we need to build those partnerships. And I think that's really important before they go out in any practice or placement.
Very true. That's really, really important. Thank you, Shuri. Really, really powerful messages there. Mohammed and Gizem, would you like to add as well on this particular aspect of collaborative work in order to progress this kind of this field?
I'll let Gizem start.
Actually, I'm a quite new researcher, so I need my collaborations too, but being a part of a FIP academic pharmacy section gained me a lot of inputs to enhance my network. So it might be another way to select FIP as a network to enhance your network. And then, for example, researching, finding out what your region needs in terms of this cultural sensitivity training would be a starting point. So, for example, focusing on patients' perspective, focusing on pharmacist perspectives, and conducting new research, basically qualitative ones, would make you find out what your region needs for this cultural sensitivity and where to start exactly.
Yeah,
I think keeping an eye on the literature, because sometimes you would see someone who's working on something very close or something that you'd find very interesting, and sometimes, you know, just don't be shy of sending someone an email and like, you know, I like what you've done with this. This is what I think we can, you know, join forces. And if they're up for it, I think it would be a great thing to do. I think it's another thing that, as Gizem mentioned, like the networking opportunities that you may have. I think sometimes showing your work is the first step into, you know, having people know where they can collaborate with you as well. So I think considering disseminating your work, sometimes a lot of pharmacy educators do some cool things, but they never make it to the literature. So consider working on your methods, publishing this in the AJPE or Pharmacy Education, the FIP journal, or CPTL or other places, so that we can share those experiences.
very, very important indeed. And on Gizem's point on the collaborative opportunities within the FIP platform, I think I could weave in here as well that a lot of the work that you're involved in this topic is also linked to a couple of the FIP development goals. So we have 21 FIP development goals that have been set for the decade ahead to transform the profession globally. And it just occurred to me that a lot of this work links to development goal number 10 on equity and equality, but also on development goal number 15 on people-centered care. So I think this is quite important that we are able to make these linkages as we progress with our work. I also would like to have one more look at the Q&A. We have a comment from our colleague, Sharon Connor, who says, thank you for an excellent presentation. And there's a question from Sharon. Thank you, Sharon. What tools do you recommend for students to use to best assess their cultural identity? Who would like to take that one? We can go in turn. Thank you.
And I guess I could probably take that. I mean, we start off the session with reflective prompts. So we look at, there's obviously lots of different reflection models. There's Sean's, there's Gibbs, there's John's, there's a number of, you could pick one of those things. But we actually start with, you know, what do you identify with? What are your sort of beliefs? What's your value system? What are your attitudes towards, you know, X, Y, Z. So we start to just have a sort of open up the room for a bit of a discussion and a very kind of friendly discussion before we delve into anything more serious than that. So I guess the use of evidence-based reflective prompts as a tool, possibly. Any other tools that are used out there?
None that I know of, honestly, because my work hasn't really explored that. I've worked with other tools that have students reflect on implicit bias and how that relates to culture, but not really necessarily reflecting on their own culture other than the things that Sherry has mentioned. So
because part of cultural safety and cultural sensitivity is that they really think that you can't really reflect on someone else's culture if you haven't reflected on your own. So understanding your own cultural identity is extremely important in that process. And once you've sort of got that and you have a kind of clear understanding of that, you've got more of an idea of respecting someone else's differences. And so that is part of the sort of the training. So the part of the training is understanding yourself first.
exactly.
Very true.
Exactly.
Thank you so much for that, Sheree. Thank you, Mohammed. Kazem, do you have any further comments at all at this point in time, or anything that you'd like to share?
I can recommend a reference that is really essential for trainers, I think, to look up for. Essentials of Cultural Competence in Pharmacy Practice is a really, really impressive book that you can guide for.
Is this something that we could share with our
yes, I can
via
type.
chat box?
Yes.
That would be great. Thank you so much for that. We are running just on time, everybody. And if there are no further questions from our audience or any further comments from our speakers, I will like to thank you all for participating in today's webinar and thank FIP for hosting this very thought-provoking presentation. Are there any further comments, Mohammed or Sheree or Gazem, before I move on?
I'd just like to say thank you as well for the opportunity to be involved with this event. Thank you.
Absolutely. Thank you, Delia, for moderating this. It was a pleasure being with this panel and having this discussion and getting those interesting questions from the panel. So thank you, and from attendees. So thank you, everyone.
Thank you, Dalia, as well, for moderating this excellent webinar and to give me the chance to be a panelist on this webinar.
You're very, very welcome. I would like to share as well my own sincere thank you to the three of you. It's definitely been an eye-opener of presentation, learning from your experiences and your area of expertise. I really appreciated the opportunity to moderate. So thank you so much, Sheree, Mohammed, and Gazem. I'd like to let our attendees and the listeners to this webinar to know that the recording of this episode will be made available on the FIP website via fip.org/coronavirus. That is a web page that includes all of our COVID-19 resources. This is an opportunity as well for me to invite you to also join our new Facebook group, COVID-19 and Pharmacy, where you can join a global network of pharmacy discussing the pandemic. We also invite you to check all future FIP digital events on events.fip.org. Stay tuned as well for our next event on the 18th of May, the first episode in the Hearing from Our Heroes series. And it will be focused on hearing from our young pharmacist heroes, which is a follow-on actually from a session we conducted in 2020. Please note that there will be a 4-question survey that will pop up at the end of the event. We request that you please give your feedback so we can continue to improve our digital event offerings. Thank you so much, everybody, for being with us today, and good day to all of you. Thank you, speakers, best wishes, and stay healthy and safe, everybody. Thank you so much. Goodbye for now.